Hello, I'm Larry Levitt from KFF. Welcome to the latest episode of the new KFF series, The Health Wonk Shop. Roughly once a month, we dive into timely and complex health policy topics with experts from a variety of perspectives. Today, we're talking about the future of mental health coverage and access. Over 30% of adults report symptoms of anxiety or depressive disorder, and that's almost tripled from 2019. More than 1 in 4 people with these symptoms say they needed care but haven't gotten it. In 2019, before the COVID pandemic, 19% of teens had seriously considered attempting suicide in the past year, an increase of over 1/3 from a decade before. The pandemic has only increased these problems, but also maybe increased our will to address them. President Biden has proposed steps to improve access to mental health care as part of his unity agenda, and members of Congress from both sides of the aisle have started to work on legislation. We're joined today by an impressive group of experts to discuss all this. Angela Kimball is a senior vice president at Inseparable, a coalition focused on improving mental health care policy. Ben Miller has a doctorate in clinical psychology and is president of the Wellbeing Trust. Brad Lerner directs public policy on behavioral health issues at Anthem, a major commercial insurer. And Kay Pastena is a vice president at KFF and co-directs our new program on patient and consumer protections. She previously was a principal at Mercer, the benefits consulting firm, and served in numerous roles in the federal government. If you have questions at any time, submit them through the Q&A button in Zoom, and we'll get to as many of them as we can. Note also that this session is being recorded and an archived version should be available later today. Angela, let me start with you. There is now maybe more discussion than ever, certainly in my career, among policymakers about addressing mental health care. What do you see from your perch as the top 2 or 3 priorities for federal policy to address here?
Oh, that's a great question. Thank you, Larry. So I'm going to say what I think ought to be the top questions that policymakers should address versus what they may be thinking about addressing. And I think this starts with a fundamental assertion that if we want to improve mental health care in this country, we have to move away from relying on a grant-funded public system. And that means that we really need policymakers to look at 3 major things. 1, requiring appropriate coverage by all health plans, including Medicare, and effectively enforcing it. I'm not saying parity because while that's needed, it doesn't go far enough. A second piece is financing full integration of behavioral health care into primary care, from pediatrics to geriatrics, and the cost of delivering effective treatment. And finally, measuring and incentivizing access to and quality of care. Those are 3 fundamental policy areas that we need elected officials and the administration to be focused on.
So Angela, let me just follow up quickly. You talked about these as being what you think should be the priorities, but not necessarily what are the priorities. How do you see the current debate diverging from where you think it should be going?
There is still a lot of emphasis on, for example, the reauthorization of SAMHSA, the Substance Abuse and Mental Health Services Administration, and essentially grant-funded programs. And that does not get us to a service delivery system where mental health and substance use services are fully integrated into our healthcare coverage and delivery throughout the country.
Great, thanks. So Ben, Angela just talked about a service delivery system. A service delivery system needs people to deliver the services. Otherwise, people aren't going to get the care they need. There are kind of diverging views of how much of a workforce shortage we have in mental health care. How do you see the magnitude of the shortage, and what are some of the short and long-term strategies for addressing it?
Well, thanks, Larry, and thanks for having me on. First of all, I think this is the most fundamental and foundational issue in any conversations we're going to have around mental health reform. You got to have people in the places that they need to be to do the work. So I know KFF has got a pretty wide viewership of your material. So if Elon Musk is watching this today, I've got a $44 billion proposition just for him. And it could change the lives of everyone in America. And we have to really invest in our workforce. And let me give you kind of a couple of ways that we can do this, both short and long-term strategies here. First, and probably most obvious, we have an amazing group of clinicians that are out there on the front lines taking care of people every day. The problem with a lot of those clinicians is that sometimes they're just simply in the wrong place. We have created a structure within our system where we ask people to go to certain places to receive care. And if you talk to anybody on the street, they'll tell you, well, I actually want care to come to me. So we've got to reverse that trend. We've got to think about ways to get those clinicians that are already out there, well-trained, doing good stuff, into the places that people are. That could be schools, primary care, you name it. The second is we got to look at the future workforce. How do we really begin to go into our graduate schools, our medical schools, and equip people to learn how to work on teams? We know from the evidence that team-based care is hands down much better than just me doing it on my own. And the problem is that a lot of folks still come out ready to hang up their single shingle and say, I got this, without really an acknowledgement of what it's like to work side by side in a multidisciplinary fashion. That is the future of healthcare in a nutshell. We've got to be doing this together. It's more effective, it's more efficient, it's better for the people. The third, though, is the most radically transformative idea, which is more of a long-term strategy, yet it could actually be done tomorrow if we were bold, which is how to empower communities to have the skills and the resources to begin to address issues of mental health and addiction on their own. This is the democratization of knowledge and programs, all this stuff that we sometimes hide away under the bushel of a clinic. We got to get it out there and put it into our communities so that the folks that are, well, I don't have much hair to trim left anymore, but they are trimming your hair or talking to you with your morning cup of joe, they have basic skills to know how to address those issues that confront us in every walk of life around mental health. Just imagine what would happen to how we would change the way that we thought about workforce when everybody was better equipped to be able to help someone else. To me, those are big, massive strategies that have different policy implications, local, state, and federal, and I'm sure we'll get into that.
I've got no hair to trim either. Talking your bold step of putting these resources into the hands of people in the community, putting this knowledge into the hands of people. How do you see that dovetailing with discussions around how to address pandemics, and creating a community health workforce to deal with that?
Well, I think somewhere along the way, we absolved ourselves of the responsibility that mental health was something that we should take on. Kind of like public health. We said, oh, that's what they do over there. But really, if you're a good student of public health, you recognize that a fundamental aspect of prevention begins with just you and what you do with those around you and your own behavior. I mean, we've known this from tobacco over the years. There's a lot of things that we know about prevention that sometimes don't get baked into a lot of broader conversations on mental health. So personally, I think that this is something where we are going to have to pay a lot more attention to, because as we'll get into later when we talk about 988 and some things that are probably coming our way, there's always going to be a person that's near you or in proximity to you that could be the first most impactful intervention on your life. And you can apply that to every setting, not just mental health. You could talk about COVID, you could talk about personal responsibility, mask wearing, vaccinations, you name it. But usually it does come down to the persons that are most close to you and what they do or recommend to you for your help. And going to the emergency department or going to call 911 isn't necessarily the most helpful solution for folks. But if you were able to have those skills to help them, imagine how that changes an entire trajectory of someone's experience.
Great. Well, we will definitely come back to the coming 988 hotline. So, Kay, let me turn to you. So Angela talked about parity not being enough, but it has been such a focus for years in improving coverage and access to mental health care for people with insurance. Kind of give us your elevator speech on parity to begin with. Kind of who does it apply to? Who doesn't it apply to? What does it do? What doesn't it do?
Sure, I'll set the landscape a bit. I mean, these are federal rules that have been around in some form or another for 25 years. I feel like I've been talking about it for 25 years. And of course, the goal of parity is to address the disparities in health plans and how they cover mental health and substance use disorders compared to how they cover medical and surgical benefits. And so Congress sought to address the historically lower level of coverage for behavioral health by requiring plans that offer behavioral health, and that's a big caveat, if they offer behavioral health benefits, that they ensure that coverage is no more restrictive for behavioral health than for medical. And that the law has expanded over the years. The initial law in '96 was pretty narrow, just dealt with aggregate dollar limits. But in 2008, we had a much broader expansion and the passage of the Mental Health Parity and Addiction Equity Act. And the scope of that law expanded from mental health to also include substance use disorders. And it requires parity in not just aggregate dollar limits, in financial requirements. So that's your copays, co-insurance, as well as treatment limits. And treatment limits are quantitative. It could be visit limits or day limits. And treatment limits can also be as non-quantitative, the NQTLs I know Brad's going to talk about. These are the limits that are harder to understand and get to and to change. Those are things like prior authorization, medical necessity, clinical criteria, guidelines, provider network, admission standards, and certain exclusions. So it applied rules to those, and it also applied parity to out-of-network benefits. But when that law was expanded in 2008, it took several years for it to really take shape. And with final rules not really coming out until at least 4 or 5 years later, so much parity took a back seat to the ACA after it was passed in 2010. But now we have kind of a set of protections that have been in place since 2013. And those 2013 rules applied to employers, both their self-insured and insured plans. It also, the ACA applied the protections to the private insurance market, the small group and individual insurance market and large group market. And also these rules apply to certain Medicaid plans too. Final rules came out in 2016 that are pretty much similar, substantially similar to the rules that apply to the private sector, that apply those protections to Medicaid managed care plans, alternative benefit plans, and certain CHIP plans. And if, in a nutshell, these are complicated rules, but in a nutshell, there are 3 broad sets of standards that have been set over the years. First are these kind of numerical tests designed to assess parity in cost sharing and in quantitative treatment limits. And these are based on a cost analysis. Plans have to do a cost analysis based on their claims data, unique to their own plan, to kind of figure out these numerical tests. So that's one set of standards. There's also the set of standards, this multi-step evaluation of the non-quantitative treatment limits. That kind of looks at every limitation a plan has on scope and duration of coverage that's not expressed numerically, to determine whether the factors used to develop that limitation are comparable for behavioral health versus medical, and that they're not applied more stringently on behavioral health than medical. And then third, the last piece is our disclosure parts of the rules that require plans to disclose to enrollees the medical necessity criteria used in making coverage decisions. Also requires providing the reason if a claim is denied for behavioral health, parallel to claims review regulations. And then more recently, the requirement for plans to conduct a comparative analysis of these non-quantitative treatment limits, comparing the processes and factors behind these NQTLs, whether they be prior auth or network adequacy rules, compare those that apply to behavioral health to those that apply to medical, and disclose those to federal agencies upon request. So those are the 3 big picture parts of the mental health parity law. Controversial over the years. I mean, there has basically been criticism that the agencies have been slow to enforce, that plans haven't really addressed compliance sufficiently, and that the standards themselves are confusing, complicated, and fragmented oversight as between federal and state actors have been confusing to consumers and hinder somewhat consistent enforcement. So because the Department of Labor is the entity that regulates employers, private employers, CMS has some responsibility for employers in their state and local government employers that have not opted out of having to comply with mental health parity. And then CMS is also there as a fallback when states, who are the principal enforcers of this law in the insurance markets, don't substantially enforce. So lots of places to look to, and can get quite confusing for consumers.
So Brad, let me bring you in. These quantitative limits. What's the copay for a visit? I mean, that's relatively straightforward. It's a $10 copay for a primary care visit, a $10 copay for a behavioral health visit. These non-quantitative treatment limitations are obviously fuzzier and more complicated. From your perspective as an insurer, how do you see those? I mean, how do you answer criticism that they are being applied more stringently in mental health than in physical health? How does an insurer approach these questions?
Yeah, no, thanks, Larry, and thanks everybody for participating. This is great, and Kay gave a great rundown of sort of the landscape, and I think, it's important to remember that as the law has progressed, you pointed out that there's sort of this difference with the numerical, the cost sharing, the visit limits, the age limits, the numerical. We've seen a lot of improvement in that space, and really, as the law has matured, it is focused more on these non-quantitative treatment limitations and the challenges that they present. But I think it's also important to see the progress. When I first started working 13 years ago on the parity, we saw blanket exclusions, we saw mother may I's after a certain number of outpatient visits, things that have been rectified for the most part. I think where we're seeing now is when Kay was giving the trajectory of the law, the Consolidated Appropriations Act introduced this sort of codified 5-step approach that Kay sort of walked through for analyzing non-quantitative treatment limitations, and the increasingly granular analyses that are sort of required to compare. It's easy to have an example. Well, on the physical health side, they never do prior auth. On the behavioral health side, let's say in a category, they always do it. Well, that's an extreme example. That's not really where the world is. So when you're looking at a more detailed analysis of factors and evidentiary standards, what we've made quite a bit of progress. Most of the large payers and employers have multidisciplinary groups with compliance, legal, clinical, network, all working together to try and put together these comprehensive comparative analyses. I think, what we've encouraged since the CAA came out, there was a set of FAQs that the tri-agencies released, and there will be a future rulemaking as part of the CAA to again continue to hone the non-quantitative treatment limits. And I think there's a strong idea of what not to do, but we're now at a mature state to be like, well, what's the model to do? What are the green flags? What looks like enough information in this granularity? What are sort of the model sort of responses that will actually show, compliance with that level of detail that is required by the law? So I think we've seen progress. We continue to work very hard on this, and I appreciate the discussion with my colleagues on this important topic.
Great. Angela and Ben is a clinical psychologist. Angela is someone who represents people who need care. How do you view this question of these non-quantitative treatment limits? How good is our ability to determine when care is necessary and when's not, and in what ways do people fall through the holes here?
So Ben's turning to me. I'm not a clinician, so I can't tell you about, sort of the clinical criteria. But what I can say is that all across the country, we're hearing from people who are being denied care. They can't find a provider. When they find a provider and seek effective care, it's being denied. And when we look at the 2022 MAPIA report to Congress on, the federal parity law, none of the comparative analyses reviewed by the Department of Labor contain sufficient information upon initial receipt for the Department of Labor to determine whether or not they were actually following the law. So what we're seeing is essentially, as Brad has mentioned, we're into the finer details of parity, and the effect is not what we believe Congress intended. People are not getting access to care. They're getting denied. And frankly, people are being harmed.
And let me take that just one step further. We did some work about a year ago with a mom who had had their child's care improperly denied. And she just described to us the frustration that she felt, almost the frank confusion of where to go, the misunderstanding of the rules, and everything kept coming back to her needing to have all the answers. And there's just something very cruel about that in those moments when you're at your worst or your family's at their worst, that you have to work harder to both get the access you need, but to understand the benefits that you've been given. So she created a guide for us that was really, it was called Healthcare for the Relentless. And I'll put it in the sidebar here in just a second. And it was a guide that explained what everybody should know about your benefits and what happens if there's a denied claim. You know, forget the acronyms for just a second. Most people they won't even say NQTL once in their life. You know, we use it all the time, multiple times a day. You know, what it comes down to is that people need to have an easier way to understand what's actually allowed under their benefits. Remember, most folks don't understand their health insurance until they're sick, and then by then it's too late, and there's rules that are still, it takes many of us years to pay attention to. So I think that's one piece, is we've got to remove that onus of responsibility on the patient, on the person, on the family, and really put it at a different level of authority. The second thing, which I think Angela just said really well, is like we could do the magic wand game, which we do in clinical care all the time. You know, if you had a magic wand and what are things going to look like in 5 years? You know, I think that most people would say that, yes, we need to fix parity. It is a big problem and we got to do something about it. But it is only one piece of much broader problems. It's not going to guarantee that you're going to be able to get the care you need. Remember, we are watching clinicians drop out of traditional coverage areas, private insurers and the like, especially public payers, and going, cash only. And that does not help increase the ability for our communities to be able to get that timely access to care. Second piece to that is that we know that care is fragmented. We've already discussed this, all of us in our own very special ways. But just because my benefits are going to cover something doesn't make it easier for me to find the person that, can help me. And we could talk about the ghost networks and network adequacy and again, all these fancy policy terms. But really what it comes down to is what we started at the beginning, is that our nation has had a problem for some time. We've continued to put funding into the same structures that are simply inadequate to meet the community's need. And in doing so, we've made it really frustrating for folks, which is why we should not be surprised at all to see some of the data trends go in the wrong direction as we have over the last decade or so.
So Brad, let me come back to you on this question of networks. And, it's certainly an issue one hears about a lot, that it's, it is hard to find an in-network behavioral health provider. What's your assessment of how these networks do stack up? And as an insurer, can you give some examples of what you're trying to do to improve that?
Yeah, Larry, I think that this whole time that, we're at such a precipice of such an important time where we have the president talking about mental health, we have Congress talking about mental health, and we have the opportunity through a lot of great policy work to, look at the systemic challenges that have faced the mental health and substance use workforce. And I think there are some really great ideas that have been presented. I think the use of peers is something that we've really talked about, and that getting that reimbursement at the federal level for that type of workforce. We've talked about certain additions to certain licensures, certainly in the Medicare program that we have supported licensed counselors and the sort of expansion there and looking at the top of the license. But I think the biggest story that we'd be remiss, I think we're 25 minutes here, is the telehealth story also, and the telehealth flexibilities, and just what an incredible opportunity that's going to present in access. Certainly it already has. We've seen in the 2 years that mental health and substance use is an area that is really ripe for this. We certainly did it before the pandemic, but it caused sort of the pandemic to create that groundswell. And we're learning that it's not only expanded, in terms of modalities, but the type of people who would be willing to get therapy. People feel comfortable with that. And it's actually, so it's expanded the demand in some ways, and it's created different opportunities. I had read a New York Times article where there was a child who was afraid of her closet, and they actually took the iPad into the closet with the therapist, with the child to talk about the fear. And I think we're seeing this opportunity, again, as this is a policy discussion, all of these flexibilities that have been put into place, and some that, you know, we've been really looking to support, whether it's cross-state licensure or the Ryan Haight Act, continued relief there. These are all ways that impact all of the sort of buckets of areas, whether it's workforce, integration, youth, parity, you know, these pieces of foundational policy change, I think, are really important. And I'm glad we're having this discussion now, you know, at all levels, because I think these changes have been discussed for a while, and I think we can really see that the imperative.
I mean, telehealth use has exploded. I mean, we did an analysis with Epic showing that about a third of outpatient mental health visits in mid 2021 were through telehealth, up from almost zero but before the pandemic, and it's persisted. Whereas with non-mental health visits, it has fallen off. Angela, with telehealth, I mean, what does this solve all the problems? What should we be thinking about from patients' perspectives?
From a patient perspective, I mean, telehealth has been a godsend, as Brad sort of inferred, but it needs to be permanent. It needs to be paid for. It needs to be portable. It needs to follow people where they are. So this can't just be a piece that is allowed under the public emergency. This is something that needs to become part of our permanent service delivery. But at the same time, telehealth, while it's been fabulous for many, many people, doesn't solve all the problems, because there are a lot of individuals who need it. And Ben has spoken about this team-based care, and that's very hard to deliver over a telehealth visit. So we have particularly seen people who are homeless being harmed by the lack of in-person care, or people with very intensive, complex healthcare needs. And that is something that's much harder to do with telehealth. So it's not a panacea for everything, but it certainly is an incredible tool that we really need to promote.
Well, I have a lot of more questions to ask, but we've also got a ton coming in from the audience. And one I want to make sure to get to is to put a race and ethnicity lens on all of this. And Ben, maybe I'll start with you. You know, what disparities do we see in access to mental health care, and what are some of the strategies being talked about to deal with that?
Yeah, if you look at the literature, which I know many of the folks watching this have, the medical disparities or physical disparities are mirrored in the mental health side. So when we see lack of access or we see lack of improvement, it's almost identical as on the medical side for communities that are poor, underserved, communities of color. And those things have not gotten any better. And let me just give you one tangible example of this, Larry. So if we look at the opioid crisis and really how our country has tried to manage this really pervasive problem around addiction for the last couple of decades, some communities, especially after major public policy changes have occurred, have improved. And those communities are mainly white communities. And you can see this very clearly in the data around opioid overdose deaths. Whereas communities of color, Black and brown communities, have not seen that same type of improvement. They've actually gotten worse in some cases, which from a public policy perspective, I know we have to be careful with our words sometimes, but if you are not applying equity within your thinking or your framework, you're going to miss entire populations that could be negatively impacted by your decisions. And so in this space, I think it's really important that we begin to go back to something that I said at the beginning, which is how do you meet people where they are? By going neighborhood by neighborhood, community by community, becoming much more granular in our approaches, we actually can address some of those broader social issues that I believe really contribute both positively and negatively to our mental health. And so that may mean looking at recruiting folks to work in certain areas that they're not. It may be by recruiting the students in the high school who are going to go back to that neighborhood when they graduate to become the next phase of a clinician, so that they go home and they help their friends and their colleagues around them. It might be a number of strategies like that, but I'm terrified, and we can use telehealth as just one more example here. I'm terrified that if we do not pay more attention to these radical disparities that continue to just like appear in front of our eyes every day, things in our nation are not going to improve. And telehealth, as we've seen, yes, it's been really helpful for some people, but for other communities, especially when we incorporate the broadband issue, it has not helped. And so to necessarily, I don't want to necessarily go there just now, but I do feel like if we are not paying attention to that in terms of an issue of disparities, then we will all fail.
So Ben, you talked about bringing care to where people are. So one thing coming this summer in July is a new hotline, 988 for suicide prevention. A tremendous opportunity, but people need to know that they can actually be connected to services if they call this hotline. Angela, do you think we're ready for this hotline to come on board? What are some of the challenges we're gonna see?
Not by a long shot. We just aren't. So local call centers simply don't have the capacity to meet current demand. And that's particularly true when you look at the data for text and chat. And yet that is how so many, particularly young people, want to engage with a 988 call center. So one, we lack that capacity just there. Secondly, call centers are not uniformly trained in how to answer the complete breadth and depth of behavioral health calls that they may get. So there's some challenges there just in terms of that capacity. And then secondly, not all calls can be resolved just over a phone line, a text or chat. There's a need for mobile crisis teams for a subset of those who are calling with an emergency of some sort. And while there is a growing number of mobile crisis teams across the country, including child-specific teams, many states don't have mobile crisis teams, or certainly don't have them covering all parts of their state. And then finally, some people will need crisis stabilization services, whether it's crisis residential or a 23-hour stay, et cetera. And frankly, that is the newest kind of level of service that is least common around our country. And we really need all three of those pieces. And as Ben will attest, we also need wraparound aftercare supports, prevention, to create this continuum of care. We're not ready. And frankly, we have federal elected officials and state elected officials seemingly pointing fingers at each other in terms of who's supposed to foot the bill. Meanwhile, people are still dying on our streets and being boarded in emergency departments and put in jails.
So actually, you touched on several important issues there. So one I want to talk a little bit about is, and it's come up in the questions from the audience, is youth specifically, and how to reach youth, whether through chat or whatever, and whether hotline is the appropriate mechanism. But also then how do we get services to young people? And we talked a little bit earlier about schools. Kind of what role do schools play here? And Ben, maybe I'll start with you.
Well, remember, kids are going to spend more time at schools than they are in any other setting. And so it is the prime location for us to really, again, go back to my bumper sticker, meet them where they're at. And so it's a shame, and Angela could talk about some of the data that Inseparable has done around the schools and the report card, the amazing report card that they did. But most schools are more likely to be staffed with a police officer than they are a mental health counselor. And so you've got kids that are showing up in need and having nobody that can really help address that need. That is a fundamental issue of policy. And we don't need to get into the weeds here. It's actually pretty simple. How do you make sure that schools are better equipped and financed to have the on-site resources and care provisions that are necessary to meet the needs of that community, full stop? And in order to do that, it requires us to get outside of some of our very traditional siloed thinking about where the dollar goes and how the dollar pays for quote unquote care. And I think there's a lot of opportunity in that space. One other thing I'll say, which I think is really key for the youth, especially in the schools, is that the data will show that youth are much more comfortable talking to each other and receiving help from each other than they are from folks like me or you. And so how do we begin to go beyond just like having access on site to schools to really increase the training that our youth are given around mental health, to make it a part of their overall portfolio so that they are just learning basic skills to help each other? Just like when we were all growing up, we didn't have somebody that was talking to us about social media and how you can't put certain pictures of yourself online. But yet that's a conversation that every parent in America has with their kids these days. Okay, we need to be doing the same thing with our kids around mental health in schools. It's just a natural part of how you will engage those around you. And by better understanding their mental health, your mental health, you're actually going to improve everybody's mental health.
So Kay and Brad, let me bring you back in. And we had a question from the audience about sort of how some of what Ben is talking about different models of care, bringing care to where people are, how that meshes with our insurance system, our private insurance system. For example, team-based care. Are there mechanisms to cover team-based care in private insurance? Kay, maybe I'll start with you. Sort of what I mean, from a regulatory standpoint, from a legal standpoint, what are insurers required to pay for here when it comes to mental health benefits and substance use benefits?
Well, I think that was the major part of parity and its limitation is there aren't really bright line rules or external benchmarks to meet for what should be covered, particularly for a large employer or a self-insured employer that's not subject to state mandates or state reforms. That most large employers do provide benefits, but it's often not clear the extent and depth of the coverage, and only upon getting denied at a very pivotal point for someone, particularly with serious behavioral health conditions, do they see the limits of the plan. And a lot of issues have been discussed around clinical guidelines and what's used. There's no requirement that clinical guidelines necessarily meet a certain level of or any type. And I think that's an issue that's been being litigated across the country. So there are no standards there. But I will say that having, since the pandemic, I've seen in my work, employers really looking for the first time really at what they are offering, particularly to for the employees, even whether they have insurance with the company or not. What can they provide to employees in terms of meeting people where they are, whether it's a more modernized EAPs, employee assistance programs, telehealth, all of those things that then they might be able to provide to employees, regardless of whether they're covered under that employer's plan. But of course, those miss the issues around the dependent coverage. And I think so much of the tough stories we hear are children who have health insurance through their parents' employer, who for some reason cannot access whatever the care it is they need, whether it's residential treatment, or for kids with developmental disabilities, coverage for certain therapies. So no, I think the bottom line is there's no particular standard. Some employers and insurers do it better than others, but it's not often very transparent to the consumer when they're choosing a plan how certain behavioral health care is covered.
Yeah, I would just jump in to talk about that. I know at Anthem, there are a number of innovative programs that we've looked at there, tying to the youth. There is a suicide prevention program that we have worked at to try and reach out and try and catch. It leads to the prevention and early identification. So how do we reach these people before, as our Mental Health America, before stage 4? What are the things that we're doing to pull people in? We have Massachusetts Child Psychiatry Access Program to try and, there's a shortage of child psychiatrists, trying to link up providers. There's in the substance use space of Project Echo. So there's a number of programs that we are trying to build upon to sort of create what I think Ben is looking at is like different points of entry and different ways to make sure that people are expanding the treatment options.
So Angela, let me come back to you. You started the discussion talking about the limits of a grant-funded approach here, and we have a question from the audience tied to the 988 hotline that if we need to create services that we can connect people to if they call the hotline or more broadly, how do we pay for those services? We're talking about healthcare, so everything comes down to money. How do you see the financing working for those services?
That's what's up in the air right now. And frankly, Congress has passed legislation that has brought new flexibility to Medicaid. So states are getting increased FMAP federal matching dollars to develop mobile crisis teams. But that's just Medicaid, right? So that is not everyone who may be calling. And so we actually need all insurance plans to really be covering things like crisis stabilization services and hopefully mobile crisis as well. And right now, there's no requirement. And I think one of the most promising things we've seen is Washington State passed legislation that requires all state regulated health plans to essentially cover behavioral health crisis services by defining those as emergency services that those plans are already required to cover. And that's where we have challenges, is we're really talking about sort of interventions that are relatively new to the country. They work, they're in existence, but they haven't been covered. So who's going to cover them and how and why? Frankly, we believe that all health insurance plans ought to be covering them. This shouldn't be the province of just the public sector.
So Brad, I'm assuming you might have some views here.
Yeah, no, I think that, in particular, Beacon is involved with crisis services in about 6 states currently. And I think a lot of the issues that have been raised today are there are some states that are further along and have a real robust crisis system, and we can use those as models, not only for equity. One of the things Beacon's focused on is trying to imbue equity, and we have collaboratives within states to talk to different stakeholders about what their needs will be. We are also, so looking at the different components of the crisis service and making sure we have the right workforce. I think Angela had mentioned, that we're expecting that there will be an increase in calls, and, having creative ways of who could be answering the phones, but also making sure that we have the redundancy in the workforce to make sure that there's sort of a backup system in place. So there's a lot of points here that different states are in different places. I know that the federal government has also given grants to states to look at planning, and we work with them as well. So I think that this is a top of mind issue, of course, that this 988 system and all of the things that we've talked about today, all of the topics really get crystallized into that 988 kickoff, and that it won't just be a moment in time. This is going to be this is not just something that where our attention is going to turn to something else once the summer comes. This is going to be a very long process to continue to build out where the states are just starting.
Larry, can I introduce just a really important F word into this conversation, which I don't think I've heard yet, and it's around flexibility of financing. Because I think that a lot of times when we consider how things are financed, it supports this way. It's to pay for that thing. And what we've learned over time is that a lot of communities need more flexibility in creating the type of programs that are really responsive to the needs in their communities. And I use the example that Angela just gave around 988. We're seeing states really create very innovative strategies for how to solve this major problem. I just came from Arizona about a month ago, and part of the reason that Arizona is able to build out this crisis continuum as robustly as they've had is because they have a much more flexible financing mechanism within the Medicaid program. But if you look at the story there, it took close to 10 years to get to a place that it was that flexible. And I think if we don't have those conversations now on providing that level of flexibility into whatever it is we create, then we will have those further disparities, as we talked about at the beginning. It's never going to be one size fits all. There does need to be some standards in place. I'm not saying that, but there needs to be flexibility within those standards for local communities to build out what they think they need to be best responsive to 988.
And Ben, let me just follow up with both you and Angela. I mean, we started out talking about federal policy, and there certainly is a large debate on these issues federally. But then so many of the examples you all have brought up, you, Ben, Angela, Brad, have been about what states have been doing. What is the role of states here? And Medicaid is certainly an obvious source of potential flexibility and financing. What other funding sources might states have to address some of these issues?
One key financing mechanism for 988 is states being able to pass fees basically on cell phone bills. And we've to date only seen a handful of states do so. So that's another way to inject the system with very flexible dollars that can be used to support the development of a crisis infrastructure. And I think a lot of people don't realize that they already pay these kind of fees for 911 on their cell phone bills. But telecom industry has been working quietly behind the scenes, and there has not been a lot of state legislative support to move that kind of fee forward. Yet the vast majority of Americans, when they're polled, support these kind of fees, especially when they know that they are far less than $1 a month and would support a 988 crisis infrastructure.
And Larry, we can't forget that when 911 was started, however many eons ago, that it was primarily supported by a national foundation for years until we figured out the local, state, and federal mechanisms to provide financial sustainability. And I'm not saying that, you know, the foundations need to step up and support this right now. They'd be great if they did a little bit, but we need to figure out those mechanisms that Angela mentioned. Because if we don't, what's going to happen is that some states are going to pass these laws. They're going to have a surplus of resources from their local philanthropic community, and they're going to build out these amazingly robust crisis systems. Other states aren't. And those other states are going to have that increased in disparities. They're probably going to lose the trust of the public, which is something I care very deeply about. I mean, first of all, we have a communications problem around 988. We need to do a better job letting folks know what it is and when it's coming and what it's supposed to look like when it's here. I think like 4% of the public understands is aware of 988. So very few people are tracking this. But we've got to do that, because if you call 988 and you're expecting to have a different response and you get the same response, then you potentially have turned someone off from engaging in future services for the foreseeable future. And I feel like that's a huge travesty, because we have a hard enough time trying to destigmatize mental health and make sure that people understand it's okay to seek help.
Well, I think, Ben, you started this conversation with a reference to Elon Musk and whether he's watching. So, we'll see if some of that $44 billion to buy Twitter can be redirected here. So we're unfortunately at time. I want to thank all of you. It was a terrific discussion. And I'm grateful for it, and certainly thank the folks in the audience who participated as well. And a reminder that this was being recorded and will be available later today. And please join us next time for Health Wonk Shop, and certainly feel free to suggest topics for future shows as well. Thanks all.